Dear colleagues, today I will present to you a case of Beckwith-Wiedemann syndrome. The patient first presented to our clinical attention at 14 weeks and 5 days, having been referred specifically because of the finding of an omphalocele. At the abdominal level, a defect in the abdominal wall is clearly evident, through which part of the small intestinal loops herniates, with maximum dimensions of approximately 12 by 10 millimeters. Omphalocele is a rare congenital abdominal wall defect, occurring due to the failure of the intestines and other organs to return to the abdominal cavity between the 6th and 10th week of gestation. In 30 to 50% of cases, this is associated with other anomalies, including cardiac defects, chromosomal abnormalities such as trisomy 13, 18, or 21, or genetic syndromes like Beckwith-Wiedemann syndrome. Considering the limitations of such an early gestational age, no other anatomical anomalies are detected at this time, and the patient is referred for genetic counseling and pediatric surgical consultation. The patient comes back to the clinic at 19 weeks and 5 days for the detailed fetal morphology ultrasound scan, where, first of all, the presence of an omphalocele is clearly confirmed and documented, containing only a portion of the small intestine, with measured maximum dimensions of 14 by 12 millimeters. At the abdominal level, it is possible to observe the presence of two adjacent amniogenic formations to the right of the midline, which are negative on color Doppler, raising a strong suspicion of a double gallbladder. This condition represents a rare congenital malformation that affects about 1 in 4,000 births and consistently requires definitive confirmation after birth. Continuing the detailed anatomical study of this fetus, we note at the level of the left kidney a suspected double system, meaning the presence of two excretory systems, a double pelvis, and a double ureter. This is a common congenital anomaly, often isolated and bilateral in 15% of cases. In most cases, the affected kidney has increased biometry, as seen in this case, where it has a longitudinal diameter of approximately 25 millimeters, which represents the upper limit value for this particular gestational age. This anomaly, like the double gallbladder, also requires postnatal diagnostic confirmation. In both cases, these are benign malformations. Perhaps the most interesting finding in this case emerges when we move to the fetal profile. Here we can observe particular rhythmic movements of the tongue, as if trying to go beyond the lip line, an indirect sign of macroglossia. Take note of how, in these specific lips, you can see that the tongue has a tendency to extend beyond the alveolar arch. In most cases, macroglossia results in the fetus being incapable of closing the oral cavity properly. Here, as you can see, the mouth is sometimes closed at this point, but this could potentially indicate that the tongue protrusion is still at a very early stage, as it is often a gradually evolving clinical sign that, in Beckwith-Wiedemann syndrome, usually becomes more evident between 28 and 32 weeks of gestation. Macroglossia is also usually associated with polyhydramnios due to the fetus's significant difficulty in swallowing properly because of the physical and mechanical obstruction caused by the tongue itself. In this case, the amniotic fluid is at the upper limits of normal, with a maximum pocket of 61 millimeters and an AFI of 21 centimeters. This leads us to emphasize the possible progressive nature of macroglossia and the fact that we might still be in an early stage of its manifestation. The result of the amniocentesis confirms the diagnostic suspicion of Beckwith syndrome, a rare genetic overgrowth syndrome. This syndrome is characterized by a classic triad consisting of macrosomia, omphalocele, and macroglossia. Of these, in our case, only omphalocele and macroglossia are currently present, although the latter is still in its early stages. Fetal overgrowth, which is the hallmark of the syndrome, has not yet manifested, but we emphasize that it could appear later in the 3rd trimester or even after birth. Among the other clinical signs of the syndrome described in the literature are possible renal anomalies. In this case, we suspect a double left renal system, visceromegaly, which in this case is absent, and polyhydramnios, a finding we have just discussed. In the medical literature, however, a direct association with a double gallbladder is not currently described, but this could still be considered as part of a dysregulation in the development of endodermal organs, which is quite typical of this syndrome. Thank you very much for your attention.